Thank you. Thank you so much. Nice to be here with everybody. So, as was mentioned, I live and work in Buffalo, and I'm an internist by training, but I've been doing most of my career has been in addiction medicine. I'm ASAM. I'm certified now with the certification in addiction medicine. I mostly have done most of my practice in, we're going to say, resource poor kind of areas. We work in what's called the mission sites of the hospital, and so treating addiction without necessarily a lot of support, although over the course of time that's changed. So a lot of experience, kind of a primary care setting. So I recognize that it can be a challenge to use buprenorphine, but also a great opportunity. And honestly, it's really changed my career, starting to treat patients with addiction in my primary care clinic, and sort of put me on a totally different trajectory. So I really love what I do, and part of what we're hoping to do here is sort of convince everybody that this is a very good idea, to recognize that there are challenges, but again, many opportunities. And one of the things I think I want to really focus on as part of this brief presentation is for us to remember what we are up against, or what I say a lot of the times is keeping our eye on the ball, that as problems arise, which invariably they do, as they do in any other medical treatment. No medical treatment goes without some sort of issue. Nobody, no human does everything they're supposed to do. So it's no different when treating patients with addiction, but that we recognize that the underlying opiate use disorder, the untreated opiate use disorder, that is fatal. That is fatal. And so what we want to do is to try to find a way through the troubles so that the treatment of the opiate use disorder can continue. Because if that doesn't happen, then the patient is at great risk to develop complications, including death as part of that untreated opiate use disorder. So this is just a little background. This is, like everywhere else, Erie County, that's the county where we live in Buffalo. A lot of issues here. As an aside, the Western New York area, the federal district of Western New York, we have the highest rate of action against physicians in the country, actually. So we had a very large number of pain management practice and a very aggressive DA in this area who prosecuted many physicians. So that's kind of the backdrop for a lot of the issues that we have. So you can see here, this is the if we could go back to the opiate-related deaths in Erie County, and you can see 2012, 2013. This is the opiate crisis. How we could talk about that, I suppose, what that all means for people, but the prescription opiate crisis. And there was a lot of people dying. These were, primarily prescription opiate deaths, not just, but all. But, that was getting a lot of attention, and rightly so, for a county the size of Erie County, which was a little over 1 million people. But you can see here in 2014, what happened was we had what was called the I-Stops law, multiple other things going on, including all of those prosecutions of multiple physicians starting to happen. And the I-Stops law in New York mandated the prescription monitoring program and a lot of other things, and prescribing of opiates decreased. And unfortunately, what happens is just decreasing the supply of prescription opiates, as I'm sure many of you know now, does not cure the disease of addiction. And so there was really no allowance made for that. And so the prescribing of opiates decreased dramatically. The availability of prescription opiates illicitly decreased dramatically. And you can see what happened with the good intentions to decrease the problems with the opiates. We had a dramatic increase in the number of deaths related to opiates. And that's directly related from most of those patients transitioning from prescription opiates to using heroin, and in this area, fentanyl, which of course is potentially even more problematic than the prescription opiates. So we had a dramatic increase in the number of deaths over the next few years, as you can see here, rather dramatic. And so what we did, and I've been a part of a task force here to try to improve that terrible outcome. And so one of the big things we've done here is increase the training of providers for buprenorphine. I've directly provided training to hundreds of physicians now in this area. And you can see we started to bend the curve, thankfully. But then in 2018, we're down another almost 100 deaths. And we're on track for this year probably to have about 80 deaths or so. So you can see that's a rather dramatic decrease in the number of fatalities directly associated with opiate use and overdose. And that is almost directly, there's lots of things that we've been doing here, but for purposes of our talk, almost directly related to increased access to care, and particularly buprenorphine, but also methadone. The next slide. So, as we talk about these things, I know that everyone knows we talk about addiction a lot, and it's the whole thing about this, but I like to sort of frame what we're talking about with a definition. I like the ASAM definition here. It's a little bit different than the DSM-5 criteria for substance use disorder. And I like it because it encompasses really what our patients are up against. That this is a disease process which has a number of manifestations. And you see that in the definition here. It's a biological, psychological, social, and spiritual problem. And so we have to think of it along those lines. And that's why treatment should really be comprehensive. But the other thing that I think for purposes of today's talk is the last sentence here. That's what I want to focus on. That without treatment and engagement in recovery activities, addiction is progressive and can, and I will say will, result in disability and likely premature death. When you look at the statistics, they're grim. Untreated opioid use disorder, patients rarely live past 50. The mortality rate is very high. And this again, this is the backdrop for what we're talking about. That as we're thinking about that treatment is effective, hopefully that's hopefully not something we have to argue about. And that so that if that treatment is effective for the decreasing the complications of life-threatening disease, it should not be interrupted, if at all possible. So next slide. So again, it's just a chronic disease, and it manifests itself, or one of the characteristics, we should say, of any chronic disease is relapse, meaning there'll be periods of time when patients do better, periods of time when they do worse. And there are multiple reasons why that may occur. And from my perspective, just like if a diabetic patient was doing okay and their hemoglobin A1C was okay, and then in a follow-up a couple months later, now it's elevated, well, what's going on here? Generally speaking, we wouldn't discharge that patient because their hemoglobin A1C is increased. We sort of hopefully look at what's going on. Does the treatment need to be changed? What's going on in that patient's life? Did their diet change? And this kind of thing. And looking at it as a problem that should be addressed in the picture of a greater disease process that if it is untreated would cause a lot of problems for our patients. And so from my perspective, in a primary care setting, particularly, we have a lot of experience with that. And, this is should be sort of something we are comfortable with, recognizing that problems, diseases have, ebbs and flows, and that is to be expected, really. And addiction, again, is no different from my perspective. So next slide. So this is, again, keeping in mind what we're doing with, can you hit the next button too? Because it should just show. Can we hit it one more time? There we go. So this is the physiology, at least in part, of what we're talking about, because addiction is, again, it's a complicated disease, but it is at least in part a physiological problem. And people start using, that's on the far left side, this is what happens, that people use to have euphoria. And eventually the patients progress over time, that becomes harder and harder. And eventually they're using just so that they are feeling normal and not having withdrawal. And so the whole idea behind medication-assisted therapy is to put patients back kind of into a normal range, which translates then hopefully into decreased complications of use and we'll say, quote unquote, more normal behavior. And we have to keep in mind that in regards to opiates, that these medications can work quite well. But that doesn't mean that the patients never have any problems again. It's not a treatment for cocaine use disorder. But the cocaine use disorder in this, setting, I mean, if that in a way is not directly relevant to what we're talking about in regards to the opiate use disorder, and we're talking strictly speaking about the medication. This is a very common problem that we see, that the patient may be stable, so to speak, in regards to opiate use disorder, meaning they're not using opiates, but are struggling with other problems. And I would argue that those other problems, again, are just part of the greater picture that needs to be addressed, that the treatment for the opiate use disorder should continue in the setting of that. So next slide. All right, so I've already reviewed this. So, patients with addiction, if you have an opiate use disorder, so by definition you have addiction, are at much greater risk to have other problems, other addictions. And again, so it should not surprise us that patients may struggle in other areas, all right? And that this treatment should be comprehensive of all these things. And so in no way am I saying should we ignore other problems, not at all. To me, it all is a matter of how we sort of frame the other problems and our approach to the other problems. That is so vitally important for these patients, because as we see it so commonly, and it's very devastating. And actually, I was just on the phone dealing with this with the courts here right before I got on the phone here. So patients are stable in regards to opiate use disorder, struggling with other use, and then the patients are discharged then from treatment. That is very common, and that is very, very devastating for the patients, because when you look at the statistics, when patients are taken off of medication-assisted therapies for what we will say aberrant behavior, broadly defined, we could define it lots of different ways, but in this case, we'll say because of other substance use, pretty much almost 100% of the time, those patients are going to be going back to using opiates, in addition to having these other problems. And very commonly, that is fatal. Their mortality rates increase dramatically when they are discharged from medication-assisted therapy or treatment. Next slide. All right, so, the times are changing, and I'll say thankfully in a lot of ways. I've been doing this with buprenorphine since 2005, and I've been at our methadone program since 2000. And, there's been a long time, a lot of the time in there where abstinence-based treatment, medication-assisted therapy, however we want to call it now, that these things were sort of seen as, competitive or something. And, clearly, from my perspective, that is not the way that these things should be seen, that patients should be given the array of treatments. And if we're, being honest, medication-assisted therapy, if we just talk about statistically speaking, is highly effective. And that should never be really excluded from the conversation, as far as I'm concerned. And that these different kinds of treatments should be complementary, not mutually exclusive from one another. All right, next slide. So we've already gone over this. Next slide. All right, so here we go. So, again, we want to, so as we start to think about these things and reducing the harm, the clear harm that the untreated opiate disorder has for patients, that we want to keep that in mind always. And as I've already, said in sort of the introduction, I recognize that what I'm saying to you may not necessarily be easy, particularly when there's behaviors that we don't like. I deal with this myself personally a lot, and certainly the staff, that something happens and it causes concerns and whatnot, and and that's legitimate a lot of the times, but that we don't want to lose sight of what we are up against here. That when these patients are not engaged in treatment, they are pretty much 100% of the time, they are back out there having troubles again and using. So we can't lose sight of that. Next slide. All right, so one of the big issues that sometimes makes people real nervous, and again, these are all the next couple things we talk about are legitimate concerns. So don't misunderstand anything I'm saying here. Legitimate concerns, the diversion of buprenorphine being one. That buprenorphine, that this is commonly used as a, so to speak, as a reason to discharge a patient. And so One of the things I think that's important is for us all, as people who are interested in trying to treat this disorder properly, for us all to think about what this really means. It comes in many shapes and sizes. In the Buffalo area, and again, we've done a lot of work here, but up until like just a couple of years ago, and certainly this is still the case, but again, better, that there was a serious lack of access to treatment, which means that patients who wanted to be treated properly, so to speak, through a doctor or whatever, could not access that care. And so there is a market then for the buprenorphine. And if we want to decrease the risk of diversion, the best thing that we can do is increase access to proper care. Far and away, the diversion of buprenorphine is patients basically treating themselves, which I would, again, that doesn't mean that it's right, diversion, but what, I would argue, as I commonly say to staff, you know, if you were having trouble, taking pills or using heroin, I would buy buprenorphine too, if that was my option. So it makes sense that patients would do this. And again, that doesn't mean that it should be condoned, but that there are ways to address it. And from a public health perspective, the best way to address it is increase access to care. Now, in an individual patient situation, there may be, a number of things going on. My experience of diversion is that patients are still, they still have opiate use disorder, but they are using some and potentially diverting some. And so there are ways potentially that you could address that without necessarily diverting or discharging a patient, like for instance, changing the dosing and or keeping much closer eye of the patient, multiple follow-ups, callbacks, and things like that. And so this is, it's a little bit of a different mindset, but in my experience of it, sometimes we really can work through this so that, again, the patient can remain in treatment, but the diversion issue is addressed as well. And, furthermore, in my experience, it's common that the diversion is, it's not just to sell and make money, although it is for that sometimes. It's commonly someone they know. And, if we can start to develop a good therapeutic relationship with our patients, that I could sit down with them and say, listen, what's going on with my husband or whatever. I try to get to the point of it, say, well, let's get him in here so that we can treat him properly too. And so again, to me, it's all kind of a way that we look at it. Again, that's not to condone the diversion or ignore it, but are there other ways potentially to address these issues? So next slide. All right, so I sort of alluded to this already, that, aberrancy can come in lots of different shapes and sizes, but most of the time what we're talking about, what we mean when we say aberrancy, is other substance use. And, again, this is a symptom to me of a larger problem. That it should not be surprising that someone with an addiction disorder may struggle with other substance use. That should not surprise me. And just telling patients not to do it is rarely is that effective. And so it should be seen as, again, a symptom, an indication maybe that patients are not where they really could or should be. And so that we should develop hopefully a treatment plan over time that would help to address this and to recognize that this is not easy. To remain in a stable recovery is not easy. That we want to support them through that. When we look at the statistics, it's very interesting. The methadone methadone literature is very clear about this, that the longer that we can keep patients engaged, the greater the abstinence rates. The abstinence rates improve, the more and more patients are on treatment. And that the studies that I'm talking about, the one that I usually quote, is that was followed for 5 years. And abstinence rates continue to improve. I'm talking about other substances besides opiates. And so, that's one of the things I always say to myself, well, got a little more time in here. I say to the counselors, can you hang in here a couple more years maybe? It seems like a long time. But if we think about that this is, again, a complicated problem, some of this disorder, meaning addiction, is a learned behavior. And so some of this is, again, engaging patients in treatment and helping them to move to a different place to learn new behaviors. That takes time. And so, as I pointed out here, again, this is not to ignore it, but there are multiple ways that we can address these issues while not threatening their ongoing treatment for the opiate use disorder, which again is a serious life-threatening disease. So, and the last point, I guess I'll just touch on that. I deal a lot with buprenorphine providers in the area here. And sometimes I recognize that, maybe there's things that we can't work through, but then at least to have a real plan too. Okay, I don't feel like buprenorphine is proper treatment for you anymore, but I'm going to refer you to, I say, quote unquote, the higher level of care. And in this setting here, I mean an opiate treatment program or a methadone clinic. That is much preferable to just discharging the patient, because that will lead to other things. And 100%, like I said, almost always back to opiate use. Next slide. All right, so I know most people know this, and my practice is really, we've evolved to really be set up to be able to see patients frequently and to do these kinds of things to hopefully address problems as they arise. And one of the things I like about doing this, particularly, if there is a problem. Here's a problem today, but several months from now, the patients, a lot of the times they get stable, and then we can, so to speak, loosen up the boundaries again. And so to me, that's a win-win for everybody. That I'm feeling more comfortable, the patients remain in treatment, the problem is addressed, and now we're to a place where it's different. And the patients recognize then, this last bit is so important, that here where I'm here, I'm working with you here. I'm on your team. There is an issue. How you and I might see this issue, we could have some disagreements, but I'm going to try to work with you to address this as best I can without putting you at risk of going back to using opiates. And that really does help to build a therapeutic relationship, that the patients understand that. And then from my perspective, honestly, they're more likely than to engage in some of the other things that I want them to. The dishonesty sometimes that we see with some of these patients, again, this is not to condone it, but my experience is that patients commonly feel like, and in fact, their experience would suggest that this is based in reality, that if they are honest with what's going on, that there's going to be a lot of bad consequences for them that they don't like, particularly that they'll be stopped in treatment, that they will be discharged. And so we're trying to create an environment where hopefully they can honestly report what's going on so that we can honestly address it. Next slide. All right, so, I just put this up for us to think about. Hopefully this is, something that everyone sort of accepts. But, again, more and more, as I do this more and more, we're breaking down, I'll say, old ways of thinking. I'm just to say it, just the classic sense of ignorance, kind of like not understanding these things, and education is so key in all of this. But I certainly find pockets still where people believe this kind of thing. And again, like the court I was just dealing with earlier, that sort of see this as, well, they're really not stable. They're not really in a stable recovery because they're on medication. And, that's simply not true. But if we don't believe it, I think it's very difficult to then to apply that care in a way that the patients, accept it as well. So, I think to really think about what we believe, because it's very important, I think. And it does come across to the patient. And, so if we believe that medication-assisted therapy is appropriate as a legitimate treatment for chronic illness, then, how long should patients be in treatment? And the answer is, I think, and we could debate these things certainly, but I think that the proper answer is as long as is needed. When we look at the literature, and some of this is the methadone literature for sure, but it's very clear that patients who are discharged, stopped from medication-assisted therapy before 2 years, have a very, very high rate of relapse. And so that's the kind of time frame I'm usually talking to patients about. But really, honestly, it could probably be thought of as indefinite, lifelong, or however we say it. And I have no issue with that, because, that's how we think of other chronic illnesses. Patients with diabetes, we don't stop the insulin 2 years into treatment. So it's really a decision that should be made by the patient ultimately, and in concert with us, obviously. That if patients are feeling like they're ready to do this and they are stable, it's something to be considered. if patients want to do this and they have some, we'll say some sort of external reason, family doesn't like it, or they just don't want to keep being seen, or they don't like being on the medicine, and other conditions are not stable, like for instance, they're using other substances, they have a very, very high chance of relapsing back to opiates if they get off of treatment. And still they can make these decisions on their own, but we should at least be informing them of the risks. All right, next slide. All right. So, you'll put this in and, think about these things and talk about it a lot, that we're on the front lines and we want to, everybody that I meet, everybody wants to treat the patients properly, and with respect and everything like that. But, how are we doing in regards to, how we address patients, how we talk to our staff about it, how we, use language and all these things. All of that is very, very important. That it's easy, I think, for us to lose sight of how difficult of a problem this is for patients to have. Nobody wants to have this problem of addiction. It's a highly stigmatized problem. And the more and more that we can address patients and, try to prevent that, try to make it comfortable for them, try to help them to understand, that this is a disease just like any other disease. Yes, it has certain manifestations, but we want to help you and help you treat it right. And we're going to, walk through this with you. Man, does that make a big difference. I don't want to get too far into the weeds, but we've had just multiple different, really excellent ways that we've addressed that in our hospital system. And and most of it, frankly, is with education of staff, so that they understand that this is not just a moral problem, however we want to talk about it. This is a serious, serious medical problem. And just like we wouldn't be mad at, a patient with diabetes, we shouldn't be mad at a patient with addiction. And, when people sort of start to understand that, and the sort of a switch goes off, it really does make a real big difference. And the care that we give and the experience that the patients have.